Yeah. So I'm here close to the GI junction. You see the beginning of the upper part of the Barrett esophagus that is here. Try to inflate well. And we immediately see in the area, I feel you agree that the area that is the most at risk of neoplasia, it's at 3 o'clock.
Exactly. As a rule, 3 o'clock is always at the part of the less curvature of the stomach.
Exactly. And immediately in inflation, we see an area that seems to be quite different from macroscopic tip, slightly surelevated and perhaps pseudo-depressed here. We'll move, of course, to the optical diagnosis with chromandoscopy with the BLI from Fuji. And as we told just before to be online, we see here that is the aspect of post-biopsy repitalization here. And just below here, we see that the pit and the vessel are irregular.
Exactly.
Still present but irregular. That's clearly for us sign of beginning of neoplasia. I continue to do acid acetic to stain and to help me to confirm. Notably, I like the paper from Pradeep Bhandari, the time of dissipation, the time of disappearance of acid acetic. That helps a lot.
And it's very easy to use.
You can push.
It's almost free.
You can push or no. Stop. I will put in retroflexion. Go back to white light. You see the perfect aspect of intestinal metaplasia, very white and regular.
And now we have to wait a little bit.
Wait a little bit here. And I move. I like working. You see the aspect of the image is beautiful. With combination of BLI and acetic acid, you see here the perfect regularity of the pits that are opened by acid acetic. It works. And the difference with here, clearly, peel in the center of the images, it's irregular.
Yes.
And more I see this, more and more I think that there is high-grade dysplasia, at least high-grade dysplasia. So I will mark, you see the splash M knife, and you will see I take large margin. I mark with force coagulation here.
So what are the settings for the marking?
Here I use force coag effect 3. I will take all the tongue, because it will not be so much more difficult. Clearly, here it's the part will be difficult. It's on the right. But so I finish the marking, you see. It will be 1/3 of the circumference, I think. You agree with my mark? You know, the lesion is here. And we will go and begin by to do the strategy I use every time. We publish 2 times, the first theory and the validation study with 3 centers in France, is to do always the same strategy in esophageal or cardiac cases, is to do tunneling and then traction at the end of the tunneling. I will do a circumferential incision because I prefer doing my circumferential incision at the beginning to be sure of my margin. And when I have a margin, I can do the tunnel, and finally, it's not a trouble for the tunneling to have a circumferential incision. Needle out, please. Okay. Inject. Okay, stop. So I begin by the right part because it's more difficult part. Needle in. Needle out. Okay, inject. Okay, needle in. Inject. Okay, perfect. Yeah. Yes, it's good. Continue. Out. I see that they are. Yeah, okay, needle out. Okay, so I am a lot of talking on the right part. I go immediately in the submucosal space. I try to, and I cut with endocut, pushing my scope and doing some up, not to be. And you see, I check the plane immediately. Was quite at the good space. I will do trimming immediately. I can do trimming with precise sect or with force coag. Here I do with force coag because I see that there is some vessel always in Barrett esophagus. And you see with the trimming, the plane is opening very well.
So you are already in the good plane because in the esophagus, the problem when you are a beginner is that you are doing a very small incision. Exactly. And there are a lot of vessels into the muscularis mucosa. So it's not a good place for working. You really have to reach immediately the submucosal layer.
So I continue with pushing my scope, you see. It's cut slowly, but without a lot of bleeding. Okay,
Yes, it's
so
very safe, huh?
yeah. Here you see we have a good trimming and a good opening on the plane. And I can go, I will stop here because if I go from right to left, I will pull my scope and I will go back from the left to right to push my scope. Needle out. So I put my knife, I go up in the plane 2 millimeters and then I push.
Yes,
Push.
so it's
And I follow my dot. Not to lose my margin. Okay, you see I can trim here on the right part or on the left part. I prefer trim on the left part because it is the margin that will stay in the patient. And what I want is to have perfect margin. Okay, it's like here. I will finish here the mucosal incision. So I re-inject and I try to finish the incision. Here you see, and I will do good trimming. I am with precise sect now. And for the trimming in the distal part, it's like I will to do a tunneling or a pocket in the gastric part. The idea is to have a very good opening here because it will be where I go out for my tunnel. And the risk, if I don't trim enough, it's to go under the flap and to continue in the gastric side. Liquid, okay. So I will do like I do first on the right part because it's a more difficult part. Needle out.
so needle out.
Okay. Inject in the plane. You see I inject far from my dot to have a plane that is surelevated where I want to cut. Will. To stay at 6 o'clock and to be tangential. You know ESD, it's a matter of tangentiality. Needle out, perfect. So I go distance from the lesion here. You see here we see the muscularis mucosae that is more deep. I was less deep than the beginning in the right part. And here I go to my right part. Okay, I open and you see that's beautiful
Nice
because
to see, huh?
you see the matter of the esophagus. This white part is not muscle. It's the muscularis mucosae that we have to cut if we want to go in the good plane. So I will increase on the left part to have just to finish to go straight off me. Okay, and now we have this area. This is not
It's very
enough
nice
deep.
to see these vessels into the muscularis mucosa
And
layer.
I cut it, but I will cut it because there is a lot of vessel. I will cut it with coagulation current. Okay, I do the hemostasis. And then I continue the trimming. Trying to stay at 6 o'clock. Here I can go in my flap. Okay, here, still here. Okay, here it's a good trimming. And I just have to push my scope. I don't need a torquing or turning my wheel. I'm in a straight position, as I told you. And always when you are straight, it's more easy. Trimming immediately with coagulation because I know that I cut some vessel during the incision, vessel from the muscularis mucosae.
Using the cap helps you to open up the space.
Yeah, and washing a little bit
Yes.
to see what's happened.
And it's very safe like this.
Very closely. There is just a small area that is not cut. Okay, and there it's open. And I do very closely my trimming. Okay, and here I have a perfect incision with trimming. So I can go for the tunneling. Always have a look to the muscle. You see the look to the muscle here. And I use precise sect. Perhaps you can tell a word about precise sect, Phil? Because I think you are quite
Yes,
an expert of the precise sect mode.
This is the mode that we use quite in every situation for submucosal dissection. It allows you to give you a good mix between dissection and coagulation with minimal damage on the muscle. Do you agree?
Yeah, it is a smart current, in fact.
Yes.
It changes the power of the coagulation according to the impedance of the tissue, and what makes the impedance of the tissue, it's the fibrosis. and the vessel. And when you want to, in fact, when you want to increase the wideness of the tunnel, you have to go from one side to the center part of the tunnel and then from the other side to the center part of the tunnel. To always work with pushing,
Yes.
like we say at the beginning.
So it's the V-shape strategy.
Exactly, like a V. Okay, and I continue.
But you have to keep
increase.
also some submucosal fibers on the edges to maintain the traction.
The
huh?
tractionability. Yeah,
Yes.
it's a natural traction tunnel. Tunneling is natural traction. You are stable in the tunneling. Tunneling is helped to make the scope stable. I think it's here. Okay, you see the end of the tunnel. Because we have a good incision, no difficulty to find the end of the tunnel. A pleasure to go out of the tunnel. Okay, I'm out of the tunnel. I'm sure we are in the good situation. I can find here my edge of my incision to increase the space. You know, like this. I go in the right part, so not too much. That's what I want to do. So that's good. And now, before putting the traction,
Yes.
first I will suction, I will clean the knife, and I will increase a little bit the size of the tunnel in the left part. Because what is more easy for the lateral part of the tunnel is to have a wideness that is close less than the size of the cap. I go inside the tunnel and I increase the size of the tunnel. Because in fact, inside the tunnel, you are in the good situation. I will inject. The injection is powerful with this knife. That's why we have a lot of fluids that come back.
And here we can nicely see the effect of the cap to open up the space. It's very helpful in this situation.
You see, I am in the middle of my plane, and I increase from the edge to the inside of the tunnel. Okay, I think it's well. We increase. You see, now I have just a small amount for the end. Clip, I catch the suture line close, and then I pull a little bit the clip inside with the suture line, and I go with the suture line in parallel to my scope. Okay. And then I will catch the upper part. Open. Perfect. And I catch, you see, the upper part of the tunnel, not catching the muscle. Here, close. Okay. You can release the clip. Okay. Thank you. Yes, and we'll the other part. So I will begin from the right part. I close my position to keep in 6 o'clock, open the knife, and then I can work from the inside of the tunnel to the outside or the other. Voilà, and I have perfect field of view. And because I have perfect trimming, I have no trouble to identify the lateral part of the lesion. And because I do my incision at the beginning, I have enough leakage of bleeding and I'm sure of my margin. Because I do the circumferential incision first, despite doing tunneling. Because if I have to do now, I'm a little more tied and with a little more good visualization of the plane, I can make a mistake on my incision. That is clearly the most difficult part of the procedure. Okay, you know, I quite do all. I can re-inject, of course, but I don't need with the traction a lot of re-injection. So I will let
small fibers.
The small fiber, not to have a specimen that will rotate, and I do the same in the other part. I move on to the open position, I was in the closed position for the right part, and do the same in the open position for the left part. And you see it takes 2 minutes to do the edges. It will normally be the same here. And I up and left to go outside. Repositioning with the cap, catching the lateral part of the tunnel, and up and left to follow the C shape on the esophagus. Anthony, you can feel my hand. Up and left, I turn, and I go out. And with the traction, with the tunneling, with increasing the size of the tunneling, you are quite always in the good situation. Don't forget to follow the edge, and I will follow the edge first and cutting the last part after. When you follow the edge, by definition, you will find the end. And you see clearly here, the trimming was less good. So that's why we don't see as well the margin as we do on the other side. So you directly see during the procedure the importance of having a perfect trimming. You see, we see the white aspect of the incision, of the edge, so we are to the end. It's something you need to have in your mind. I will show you with a knife. You see the specimen that is less white, and here the white burning aspect is because of the edge where you do the incision. So it means that you are at the end. So you have to make some up, not to go directly on the muscle, because you have already cut the submucosal just after. So you need to be cautious at this part, you know. That's why I make some up before cutting, you see.
You hook the specimen.
You hook, yeah. As I take a lot of margin, not a trouble if I burn a little bit, just the last margin. Okay, here we cut on this part, and normally we have only small fiber.
On
you know, I was on the other side in a close position. I don't find. Oh, it's finally, it's done. I let
mechanical.
So few fiber, and it stay mechanical. And here we'll do the coagulation of the vessel. On the bipolar forceps, you see you have some bleeding vessel. Open, close, close. The matter, it's clearly a good idea, a good technology, but open. We need to be full bipolar to have a close, to have a benefit. And at this time, in Europe at least, open. All our knives are monopolar for ESD. In Japan, you have the Jet B knife that is bipolar. There is in Europe that is coming close the speedboat, but it's not. It is bipolar, but it's not the same of current and the same way to work. Open, and we wait for bipolar knife. That will perhaps the idea is to decrease close the coagulation impact. Thank you. We will show you the specimen. Okay, here you can see the specimen, 45 millimeter in this large diameter, and 40 millimeter, 45 also from here.